Welcome to the Indian Council of Medical Research Online Prescribing Skill Course 2020 for Indian Medical Graduate. I am Dr. Sandeep Kaushal, Professor and Head of Pharmacology at the Anand Medical College and Hospital, Ludhiana, and I am going to talk about common psychiatric conditions, schizophrenia and bipolar affective disorders. After viewing this presentation, please answer 5 multiple choice questions on this video and give a feedback. You will find them in the assignment section. The authors for this project are Dr. Sandeep Kaushal, that is myself, my colleagues from Psychiatry, Dr. Ranjeev Mahajan, Professor and Head of Psychiatry, Dr. Navkiran Mahajan, Professor of Psychiatry from my institution. Now, let us see the reviewers for this project. The reviewers for this project include Dr. C.D. Tripathi, Professor and Head of Pharmacology at VMCC Delhi, and Dr. Neena Samant, Professor and Head of Psychiatry at KEM Mumbai. Now, why these topics are important? Remember, psychiatric disorders is a heterogeneous group which manifests as unusual mental or behavioral patterns which lead to distress or disability. Mental disorders affect 1 in 4 patients globally. The overall weight prevalence of schizophrenia is about 0.3% and for bipolar affective disorder 0.6%. The contribution of schizophrenia to disability adjusted life years is 9.8% as compared to bipolar affective disorder, which is 6.9%. These disorders are characterized by disturbance in individual cognition, emotion regulation or behavior which is reflecting dysfunction in psychological, biological and development process underlying the mental function. Remember, mental disorders are treatable. Awareness regarding appropriate use of these medications by these physicians is inadequate. That is why we are trying to cover this up. As an IMG, you should be able to recognize and diagnose, prescribe rationally and monitor the progress for commonly encountered psychiatric disorders like bipolar affective disorder and schizophrenia. After completion of this module as an IMG, you should be able to initiate therapy with appropriate medicine selection rationally for patients suffering from psychiatric illnesses, schizophrenia, acute psychotic disorder, bipolar disorder and obsessive compulsive disorder. You should be able to justify selection of a medicine for the specified patient with above mentioned psychiatric disorders. You should be able to refer the patient to a psychiatrist for confirmation of diagnosis, for therapy initiation and for psychoeducation. You should be able to communicate to the patient and the family information and instructions regarding medicines and psychotherapy. You should also be able to counsel the patient and or family for remaining compliant to the prescribed therapy. You should be able to state the importance of close monitoring of these patients with psychiatric illnesses. You should be able to communicate to patient information and instructions regarding prescribed medicines. You should be able to refer the patient to a specialist care if needed. This is the list of topics that we found out from the document in the MCI. So, the topics which are related include mania, acute psychotic disorders, other psychotic disorders and bipolar affective disorders. After discussing with the specialist, that is psychiatrist, so we listed the priority areas to schizophrenia and bipolar affective disorders. Now, these are the various points which you must keep in mind when you are treating the patients in the clinics. Remember to involve family members in treatment regimen to ensure compliance and avoid isolation. Do watch out for adverse effect of drugs in the form of tremors, headache, sedation and urine output and adjust the dose accordingly. Do recommend treatment adherence and compliance strongly. Do remain receptive so that the patient is able to explain symptoms without any fear of judgment. Do refer the patient to psychiatrist for confirmation of diagnosis, for psychoeducation both for the patient and the family members. As a physician of first contact, there are certain things which you must avoid and never do it when you are treating a patient with epilepsy. Do not change medication or doses rapidly, do them gradually. Do not neglect the caregiver as a team member for this patient. Do not stigmatize the patient. Please ensure that medicines are not in the reach of the patient and you have to counsel the family members for the same. Do not take the symptoms lightly. Do not overlook the pessimistic thoughts like helplessness, hopelessness and worthlessness. Do not just hear but listen to the patient so that you can find out what the patient problem are and arrive at a diagnosis. Now let us look at a case scenario. We have a patient who is a 10th class dropout and is brought by family members for the symptoms for the last 10 years. She has suspiciousness against family members and neighbors. She is fearful of people, keeps herself to the room, has self-muttering, self-smiling, poor hygiene and has wandering behavior. She is irritable and has verbal and physical abusiveness even when she presented to you in the OPD. She complains of sleep disturbances for the last 4 years. She has history of diabetes for the last 5 years and is on metformin 500 mg twice a day, but there is no family history of psychiatric disorders. On general physical examination, you find she is obese with a BMI of 28.3. There is nothing else remarkable in the general physical examination. On doing the systemic examination, on CNS examination, you found that she has delusions of reference, she has delusions of persecutions, delusions of infidelity and also has auditory and visual hallucinations. So, what is the provisional diagnosis? This patient probably has schizophrenia. So, what investigation you need? There is no other investigation which is required for schizophrenia, but because she is having history of diabetes, she is obese, we need to have a metabolic profile, we need blood sugar, glycosylated hemoglobin and lipid profile. We found that the blood sugar, fasting and postprandial, glycosylated hemoglobin and lipid profile are within normal limit, probably because she is on treatment. So, we make a diagnosis of schizophrenia based upon manifestations from the history that she has suspiciousness against family members and neighbors, she is fearful, she has self-muttering, poor hygiene, wandering behavior and irritable. She is also uttering verbal and has physical abusiveness, has sleep disturbances. On examination, we found she has delusions of reference, persecution and infidelity, auditory and visual hallucinations, though other than being obese and high BMI, we did not find anything in general physical examination, and systemic examination for cardiovascular, respiratory and abdomen was unremarkable. So, what are the treatment algorithms? Now, remember, this is a patient whom we need to treat, and they will start the treatment with tablet risperidone 2 mg at night for 1 week, which will be titrated higher up to 4 mg. In addition to this, because risperidone causes extrapyramidal manifestation, so we will start the patient concomitantly with trihexyphenidyl 2 mg in the morning. This patient requires psychoeducation to address misconceptions and communicate about adverse effect of medications like sedation, risk of extrapyramidal manifestations, weight gain, menstrual and sexual dysfunction. The patients with schizophrenia might require a reference to secondary care if there is diagnostic confusion. Patients demonstrate substantial risk of harm to self or others or has catatonic symptoms, belongs to special population, is elderly, adolescent or is pregnant or lactating mother, has comorbid conditions like history of substance abuse or psychiatric illnesses, or has significant extrapyramidal or other metabolic effects. If still there is unsatisfactory response to treatment, refer to a tertiary care center where they will re-evaluate the diagnosis, look at clarification for neurological and mental state examination. They will do diagnostic psychometry, neuroimaging, address the complications because of comorbid psychiatric or medical illness and formulate psychosocial intervention and rehabilitation. Remember, the patient that we are trying to treat over here is a female who is having diabetes, so we will prefer to use a typical antipsychotic, that is risperidone. Why risperidone? Because it has less extrapyramidal manifestations, less drug interactions, is cost effective, can be given mixed in food because it is available in the form of mouth dissolving tablets. It also controls abnormal behavior. In addition to this, for sleep disturbances, we will add up a benzodiazepine like lorazepam, which is efficacious, safe and is cost effective. So, look at the prescription for this patient. So, we will use tablet risperidone 1 mg twice a day, which we can gradually increase up to 4 mg. Tablet trihexyphenidyl given 2 mg in the morning. We need to follow up this patient after 1 week and thereafter 2 to 4 weeks. Investigations and the rationale I have already discussed with you. So, once we have this patient, if the patient is doing well, it is fine, but in case the patient is demonstrating an evidence of self-harm, is not getting controlled, this requires a referral to a higher center. So, what are the common errors which are observed when we treat a patient with schizophrenia? Remember, antipsychotics are the mainstay of treatment of schizophrenia, but irrational and unjustified use could result in hyperprolactinemia and extrapyramidal adverse effects such as Parkinsonism, tardive dyskinesia, which is at times very difficult to treat. Overdosage could be associated with weight gain, metabolic syndrome and cardiovascular effects. We prefer atypical agents over typical antipsychotics because of lesser adverse effects. Remember, polypharmacy and irrational use of these antipsychotics can lead to poor compliance, which will further worsen the condition. So we do not prescribe routinely 2 or more antipsychotics at one time. So you are only required to start with one, gradually observe over a period of time. If not, the symptoms are getting controlled, refer it to a higher center. Do not use antipsychotic as a first line of treatment in elderly patient for sleep disturbances and behavioral changes. Always use antipsychotic only for psychiatric disorders, as we are just highlighting. Now let us look at another case over here. We have this 22-year-old boy who has been brought to emergency by a roommate with a complaint that he has not slept for the past 10 days. The roommates reported that he is staying up all night and disturbing everybody else in the hostel. He has bought a new Mac Air book and a digital video disc recorder, though he cannot afford these kind of items. He has been bragging to his friend that he has slept with 3 different women in the past week, and this is a behavior which is unlike his usual self. He has been very irritable and explosive and is indulging in frequent fights. He denies use of drugs or any other medical problem. There is no family history or past history of psychiatric illness. On examination, we do not find anything remarkable over here. On systemic examination of cardiovascular, respiratory and abdominal examination, there is no abnormality detected. But when we did a CNS examination, we found that the patient is elated, he is wearing a bright orange top and red pants. He is pacing the room and refusing to sit down when asked. His speech is rapid and loud, and it is hard to interrupt him. He claims his mood is great and does not require any medical help. He is stating that his friends are probably insisting he come because they are jealous of his success with women. He states he is destined for greatness. He denies having suicidal or homicidal ideation. So what is the provisional diagnosis in such a patient? So probably this patient is suffering from bipolar affective disorder, where the current episode is of mania. So what investigations do we need? With the patient presenting us like this, we need to do certain investigations which include a hemogram, a blood sugar, renal function test, serum electrolytes, liver function test, a dip test for urinary opiate or benzodiazepine, an ECG and thyroid function test. So once the reports are available, we find that hemogram, blood sugar, renal function test, serum electrolytes, liver function test, thyroid function test are within normal limit. The dip test for urinary opiates and benzodiazepine is also negative. The ECG is also normal. So we arrive at this diagnosis based upon pointers in the history that this patient has decreased need for sleep, has elated mood, he is having overactivity, overspending, he is excessively irritable, has excessive fights. He is demonstrating a risk-taking behavior, is restless. All these manifestations are for a duration which is more than 1 week. In addition to this, we did not find anything remarkable in general physical examination, though on CNS examination we have seen the manifestations which are indicative of his maniac episode. So how we treat this patient? Remember, this patient is not demonstrating a maniacal phase of his disease, and if this patient is on antidepressant, we have to stop it. As this patient had presented first time, there is no such antidepressant being used, so obviously this is not the option. So we need to use an antipsychotic and a benzodiazepine for controlling this acute phase. We need to start the patient on mood stabilizers, and for this we require base investigations. We have already done these investigations, and also need to remember that these patients, when started on mood stabilizer, might require therapeutic drug monitoring. And for this, they need to be referred to a higher center or a psychiatrist, not only for diagnostic clarification but also for further management. So how we treat this patient? We treat this patient to use an agent that is risperidone, which will help to control the acute phase. Why risperidone? Because it causes less extrapyramidal symptoms, has less drug interactions, is cost effective, and can be given by mixing in food or mouth dissolving tablets. It helps to control acute agitation or overactivity. We can also add up a benzodiazepine for sleep disturbances. We prefer to use lorazepam as it is efficacious, safe and cost effective. So the prescription for this patient looks like as follows: risperidone started 1 mg twice a day, morning and evening, tablet lorazepam 1 mg in the morning, 1 in the evening and 2 mg at night. We need to follow up this patient after 1 week, and as discussed, we need baseline investigations which would be important for this patient. In case the patient is not responding to treatment after 3 to 4 weeks or is demonstrating self-harm, we are not sure of the diagnosis, or this patient requires psychotherapy or other specialist advice, we would refer it to a higher center. So what are the common errors which are observed when we see a patient with bipolar affective disorder? Remember, mood stabilizers when not prescribed in adequate doses are of no use at all. We might select an agent, but if you are not using appropriate doses, it is no use at all. Some of these patients will require serum level monitoring, so these facilities must be available or you must be asking for them and interpreting it. Remember, polypharmacy with many mood stabilizers only worsens the symptoms, which can lead to confusion and irrelevant talk. There are associated ADRs which we must remember. For example, if we put the patient on sodium valproate, it could cause weight gain and hair loss. If we put them on lithium carbonate, they can produce tremors, thyroid dysfunction and even cardiovascular complications. In a depressed patient, remember, irrational antidepressants may lead to further aggravation by menical symptoms, and therefore the first thing that we said is, when you have a patient who has come with mania, if the patient is on antidepressant, we need to stop the antidepressants immediately. So the take home message is, when you have a patient with psychiatric disorder, they reflect a dysfunction in psychological, biological and developmental processes. They require timely diagnosis and management. The purpose of this presentation is to make you aware about these disorders, what are the manifestations and how to start treatment. These disorders are treatable and therefore they must not be left as such. Remember, they might require treatment for long term to prevent relapses and reduce severity. The treatment options include pharmacological and non-pharmacological. When opting for non-pharmacological treatment, please refer them to experts. Please do not try to do psychotherapy, other therapies on your own. The non-pharmacological treatment, as I mentioned earlier, should be done only by a trained therapist. Remember, with proper treatment and rehabilitation, we can reduce the stigma associated with these psychiatric disorders. Since a number of drug options are available for various psychiatric disorders, the therapy should be individualized so as to maximize benefit and minimize adverse effect. Remember, a good compliance is a serious issue in psychiatric disorders. Always try to have a good compliance for effective control of manifestations. These medications should be given under supervision. Also remember, social support is important for these patients along with medications. So these are the references that we have used for preparing this presentation. Dear friends, please note that the ICD-10 criteria for various psychiatric disorders are already given in the supplementary material. You can look at these ICD-10 criteria for learning objectives that we have highlighted for the psychiatric illnesses. Also, these handouts also contain information about drug therapies and the treatment modules that we have discussed as per standard treatment workflows. These are my colleagues who have contributed for this presentation. Dr. Shalini Arora, Professor of Pharmacology. Dr. Kanchan is also Professor in my department. Dr. Ranjeev Mahajan, Professor and Head of Psychiatry. Dr. Navkiran Mahajan is Professor of Psychiatry. Dr. Jasleen, a resident in the Department of Psychiatry. And Dr. Sangeeta from Department of Community Medicine. The interns who gave their input are Amit, Rashpal, Mandeep, Ankit, Prableen, Amanat, Nancy and Ishita. I am also highly thankful to ICMR for their support and for providing standard treatment workflows. I am highly indebted to experts for their constructive comments. Dear friends, thank you for watching this video. Hope you are now ready for attempting these MCQs. Please access the MCQs in the assignment section and submit the answers. Please also complete the prescription evaluation as per the tutorial, which I hope you have already seen. Thank you and wishing you a happy learning.